Coming into the second part of the maxillary anesthesia, this is nothing but a palatal anesthesia. Till now, we have seen about the nerve block which anesthetizes the buccal aspect, ASA, MSA, and PSA. Now we are going to see the nerve block is going to anesthetize the tissues which is covering over the palatal region. Nasopalatine nerve block is also called as incisor nerve block and the sphenopalatine nerve block. The nasopalatine injection will anesthetize the tissues covering the palatal aspects of the premaxilla. Just nothing but, so this is a picture which shows that the nasopalatine nerve block. So you are going to insert the needle along the incisor foramen. When you insert the needle, the area will get anesthetized will be the premaxilla. There are two approaches which includes single penetration and the multiple penetration approach. Target area will be the incisor foramen which presents beneath the incisor papilla. So this is the incisor papilla. So beneath the incisor papilla, you can able to identify the foramen called incisor foramen. So that is the target area. Area anesthetized will be the anterior portion of the palate from the mesial of the first to the distal of the first premolar. Nerve anesthetized will be the nasopalatine nerve bilaterally. Landmarks will be the incisor and the incisor papilla. Aspiration is less than 1% and the signs and symptoms will be the patient will have both objective and the objective signs. So this picture shows DCP injection technique where the landmarks will be the central incisors and the incisor papilla. The depth of penetration will be 5 mm. Multi-needle penetrations. What are they? There are 3 points of insertion. First is the labial frenum between the maxillary central incisors. Second is the interdental papilla between the central incisors. Third is the parenchyma of tissue lateral to the incisor papilla. We'll see this 3 point of insertion in one by one. First is if a labial anesthesia has not been achieved with a labial local infiltration of the area, the following injection is performed. The areas anesthetized proceed to the second injections. If not, you just stay back with the first point of insertion, which is nothing but labial frenum between the central incisor. Path of insertion is into the labial frenum with the orientation of the bevel towards the bone. Tap the upper lip to improve the visibility. Insert the needle into the frenum and deposit 0.3 ml of anesthetic solution over the 15 seconds. The tissue will get swelled up and the anesthesia of the tissue should develop immediately. So second injection, which is nothing but hold the needle at the right angle to the papilla. The orientation of the bevel is not at most relevant. Insert the needle into the papilla just above the crest of the bone, directed towards the incisor papilla on the palatal side of the interdental papilla while slowly injecting the anesthetic solution. Do not penetrate through the palatal tissue. When blanching is noted in the incisor papilla, aspirate and administrate the anesthetic solution. Third one, as I told, it's proceed from like above for the first penetration, what you have done, the same thing has to be done for the third thing also. Because like third is palatal soft tissue, lateral to incisor papilla. So third same thing has to be done. Coming into the second part of the palatal anesthesia, which is nothing but the greater palatine nerve block or an anterior palatine nerve block. So what is this greater palatine nerve block? So the name itself states that you are going to anesthetize the greater palatine nerve. So where it is located and how we are going to anesthetize, we'll see in the upcoming slides. Greater palatine nerve which comes out through the greater palatine foramen. So where it is located along the distal aspect of the maxillary second femur. So like distal aspect on the palatal side, on the distal aspect of the maxillary second femur, you can able to appreciate the greater palatine foramen. So what is it? Whenever you are like, how to identify it? It's a simple way. Yeah, you just palpate either with the help of your non-dominating finger or with the help of this is the like buds, something like a buds can also be used to palpate it. When you palpate the soft tissue from the canine premolar to the molar, you will find some depression over that region. So, for like a small depression will be there. When you give pressure over the depression, you will find a branching of the tissues in that region. So that indicates that you have reached the greater palatine foramen. Once you have identified, you have feel that and you have seen the blanched pattern, immediately administrate the anesthetic over the region. So that is the area indicates the greater palatine foramen. Posture aspiration will be less than 1%. Technique is used in 27 gauge shock needle. Area of incision is soft tissue slightly anterior to the greater palatine foramen. Target area is greater palatine nerve passing anteriorly between the soft tissues and the bone of the hard palate. Landmark is greater palatine foramen, just maxillary alveolus and the palatine bone. The path of incision advances syringe from the opposite side of the mouth at the right angle to the target area, oriented towards the soft tissue. Anatomically, this is generally 5 mm anterior to the junction of the R and soft palate. Penetration will occur through the epithelium and the needle will appear to fall into a space of less resistance. The needle should be inserted until the bone is contact. The depth of penetration is variable, but it should be usually less than 10 mm is sufficient. After you aspirate, if you have a negative aspiration, just administrate the anesthetic solution slowly in that region. Area will get anesthetics will be the posterior portion of art palate, overlaying soft tissue anteriorly, as far as till the first premolar and medial sitting midline. Complications very rarely you will find an emetema over the region and ischemia, sometimes a necrosis of the soft tissue can occur. Now, the most important complication is that the patient will have a severe pain since the skin covering the palatal will have a direct contact with the bone. In between that, you will still have some mucosal connective tissues. Because of that, you will have a severe pain when you administrate the palatal anesthesia. To avoid that, just administrate slowly. This is a summary of the two nerve blocks. It's called major palatine, greater palatine, as I told. Incisive foramen beneath the incisive papilla, and area will get anesthetized will be the anterior portion of hard palate from the mesial first to distal of the first premolar. Nerve is major palatine nerve bilaterally. The landmark is incisive papilla. And aspiration will be less than 1%, and the patient will have an objective and subjective signs and symptoms. Greater palatine foramen, and the posterior portion of the art palate and its underlying overlying soft tissue anteriorly as far as first premolar and the mesial distally to the midline. Nerve anesthetized will be the greater palatine nerve. Landmark will be the greater palatine foramen and the junction of alveolar process and the palatine bone. Aspiration is less than 1%, and the patient will have both subjective and the objective side. Coming into the other names, nasal palatine is also called as incisor nerve block and the sphenopalatine nerve block, and the greater palatine nerve block is also called as anterior palatine nerve block. Another technique is called anterior middle superior alveolar nerve block, which is other name called as palatal approach anterior middle superior alveolar nerve. So anesthetized nerve will be ASA MSA and subneural dental nerve plexus of ASA MSA that innervates the incisor to the premolar teeth. Areas anesthetized will be a pulpal anesthesia of maxillary incisor, canine and the premolar, buccal attached gingiva of the same teeth, attached palatal tissues from the midline to the two gingival margin of the associated teeth. Indications: it is easier to perform dental procedures involving the maxillary anterior teeth. Then the anesthesia has to be given to the multiple maxillary teeth when the scaly and the root planning of the anterior teeth has to be done. Contraindication is patient with unusual thin palatal tissues and the procedure which requires more than 90 minutes. Advantage is provide anesthesia of maxillary multiple maxillary teeth with single injection, simple technique and comparatively safe technique. It eliminates post-operative inconvenience and requires disadvantages. It requires slow administration. Sometimes it causes uncomfortable to the patients and sometimes it may need a supplement anesthesia. So this picture shows the technique of it. Anterior pre-puncture technique, anterior middle superior alveolar nerve block. Sometimes we need a supplement anesthesia. One of the failure of this technique complications. Sometimes palatal ulcer will develop at the site of injection. Immediately 2 days of post-operatively, unexpected contact with the nasopalatal nerve. Density of injection site causing a squid back of anesthetic and bitter taste. Coming to the palatal approaches of ASA, the nerve anesthetized will be a nasopalatine and anterior branches of ASA. Area anesthetized will be a pulp of maxillary central incisors, lateral incisors and canine. Facial periodontal tissues associated with same teeth. Indication: procedures involving the maxillary anterior teeth and soft tissue. Bilateral anesthesia of maxillary anterior teeth, scaling and root planning. Contraindication: patients with extremely long canine root and who cannot tolerate 3 to 4 minutes of administration time. Procedure requires more than 90 minutes. Advantages same as that of it. Advantages of other techniques: provides a bilateral maxillary anesthesia from single site, simple and safer technique. It requires a disadvantage: slow administration, excess ischemia, may need supplemental anesthesia for canine teeth. So this picture shows that the region where you are going to anesthetize the ASA. So initially you have to orient the bevel which is towards epithelium. A pre-puncture technique has to be utilized. Anesthetic pathway technique can be utilized very slowly, advance the needle into the tissue. Rotate the needle, just hold the needle at the 45-degree angle to the palate. Rotate the needle, allow the needle to penetrate the tissue more efficiently. Advance the needle in 2 mm for every 6 seconds while administering the solution. After initial branching is observed, just pass for several seconds to permit onset of anesthesia. Continue the slow insertion technique into the nasopharyngeal canal. Orientation of the needle should be parallel to the long axis of the central incisor. The needle is advanced with the depth of 6 to 10 mm. Note if there is any resistance is encountered before the final depth of penetration is reached, do not force it further. Withdraw it slightly, reorient it to minimize the risk of penetration. Make sure that needle is in contact with intermoni wall of the canal. Aspirate and administrate the sufficient amount of anesthesia. Failures, highly successful injections for maxillary incisor. Many supplement anesthesia of canine and unilateral anesthesia has been sometimes occurs. Complication is similar to that of its palatal ulceration, nasopalatine, and then sometimes bleeding. Coming to greater palatine canal approach. So this is like in a completion sake, I have added these slides, but I'm not sure whether you'll get a question in these slides, but just take a note of it. So it is like it's useful for you people if you get a questions from that also. Greater palatine canal approach, the target area is maxillary nerve as it passes through pterygopalatine fossa. The needle passes through the greater palatine canal to reach the pterygopalatine fossa. Landmark will be greater palatine foramen, junction of maxillary alveolar process and the palatine bone. Place a quadrant swab at the junction of maxillary alveolar process and palatine. Start in the region of second molar, palpate by pressing posteriorly into tissues with the swab. Complication is hematoma and penetration of the orbit. Sometimes the swab falls into the depression created by foramen. So it's like this procedure is similar to that of greater palatine nerve block, except the depth of the penetration is 30 mm. So just remember, like overall of this slide is you can get a question is what is the difference between the greater palatine nerve block and greater palatine canal approach? Only difference is depth of penetration is more than 30 mm. And penetration of nasal cavity sometimes can occur, that should be avoided in these conditions. Coming into the maxillary nerve block, it is an effective method of achieving profound anesthesia of any maxilla. It's nothing but the half of the maxilla will get anesthesia if you give this nerve block. Indication pain control before extensive oral surgical periodontal or restorative procedures requiring anesthesia of entire maxilla division. When a tissue inflammation or infection exceeds the use of another region nerve block. Diagnostic or therapeutic procedures for neuralgias. Technique is eye tuberosity approach. Area of insertion is height of mucobuccal fold above the distal aspect of maxillary molar. Target area is maxillary nerve as it passes through the pterygopalatine fossa. Landmarks is mucobuccal fold at the distal aspect of maxillary molar. Maxillary tuberosity is the recommended process of the maxilla. The long 25 gauge needle is recommended with the bevel facing towards the bone and the needle is guided into the foramen to 30 mm. So this is a picture shows this maxillary nerve block technique where we have to administrate the nerves called eye tuberosity block, mucobuccal fold, distal aspects of the second molar. Complication, hematoma, arbitrary approach over the incision is possible because of absence of any of the bony landmark if proper techniques is not followed. This is a picture shows that what amount of volume of local anesthetic is required for each technique. Sometimes you might get a question, that's why I added the slide, just take a note of it. PSA, if you are going to give a PSA, the volume should required is 1.8 ml to the maximum and 0.9 mm to the minimum. MSA is 1.2 to the maximum and 0.9 to the minimum, and ASA is 1.2 to the maximum and 0.9 to the minimum. Greater palatine is 0.6 to the maximum and 0.45 ml to the minimum. Nasopalatine is 0.45 minimum. Maxillary nerve block will be 1.8 ml. Thank you. And after this, we have seen the intraoral techniques, the ASA, MSA, PSA, nasopalatine, greater palatine, and the various approaches for the ASA, MSA, greater palatine canal approach, and the total maxillary nerve block, this called tuberosity nerve block approach. And in upcoming classes, we will see about the extraoral technique for maxillary nerve block. Thank you.